Dr. Baliga here. I have another terrific podcast for you, the Must Know EKG podcast. You'll find this podcast educational, like all other podcasts in this Must Know EKG series. This podcast is derived from EKGs available at mastermedfacts.com. A 87-year-old homemaker complains of lightheadedness and chest discomfort. Her primary care physician does an EKG in the office, and the EKG looks like this. Looking at this EKG, the most likely diagnosis is 1. Complete heart block, 2. Morbid type 1 heart block, 3. Venky back heart block, 4. Third degree heart block, and 5th 2:1 second degree heart block. I repeat, 1. Complete heart block, 2. Morbid type 1 heart block, 3. Venky back heart block, 4. Third degree heart block, and 5. 2:1 second degree heart block. Looking at this EKG again, and the answer is choice 5, 2:1 second degree heart block. The conduction ratio is 2:1. The PR interval of the conducted beat is constant. By definition, second degree heart block is the conduction of some atrial impulses to the ventricles with failure to conduct other atrial impulses. These are examples. The top EKG strip is a first degree AV block where the PR interval is greater than 0.2 seconds. Every P wave is followed by a QRS complex. The second strip is second degree AV block, morbid type 1 or Venky back. There's progressive lengthening of PR interval and shortening of the RR interval until a P wave is blocked. The PR interval after the blocked beat is shorter than the preceding PR interval. The third strip is second degree AV block or morbid 2 where there are intermittently blocked P waves. The PR interval on conducted beats is constant. The second degree high grade AV block is conduction ratio of 3:1 or more, and the PR interval of conducted beats is constant. Here you can see two P waves before the QRS complex, and the third P wave is buried in the T wave. The lowermost strip is the third degree AV block. There is dissociation of atrial and ventricular activity. Atrial rate is faster than ventricular rate, which is of junctional or ventricular origin. In this patient, the QRS complex is narrow, suggesting that the origin is probably junctional rather than ventricular. In patients with acquired second degree morbid type 2 AV block, high grade AV block or third degree AV block not due to reversible or physiologic causes, permanent pacing is recommended regardless of symptoms. For all other types of AV block, in the absence of conditions associated with progressive AV conduction abnormalities, permanent pacing should generally be considered only in the presence of symptoms that correlate with the AV block. A recent expert perspective says bradycardia and conduction system disease in appropriate patient populations should lead to increased index of suspicion for sarcoidosis, amyloidosis, or hemochromatosis, and Chagas disease should be considered in patients who have arrived from Trypanosoma cruzi endemic areas in Central and South America. In addition, more recently we have found that the newer chemotherapeutic agents, that is checkpoint inhibitors, are associated with AV block. Exercise testing can be helpful in distinguishing AV nodal versus conduction disturbances in the His-Purkinje system below the AV node, that is infranodal, in the setting of 2:1 AV nodal conduction. This concludes this Must Know EKG podcast. Follow me on Twitter at RRBaliga MD.